Now we're going to get started on creating secondary AV fistulas from forearm grafts. When we look at hemodialysis accesses, we've got a classification of the worst access to the best access. And, of course, our catheters are considered one of our worst accesses because while they enable us to do dialysis, the complications, the morbidity and mortality associated with the catheters is the worst of all the different access types we have. And we'll give you actual numbers here as we move through the WAAVX. Then, of course, the graft is in between. And, we'd rather have somebody with a graft than have a catheter, but then, of course, we want to, if at all possible, have our patients with AV fistulas because there's less morbidity, there's less mortality, they last a lot longer than the other access types. Now, I don't know if you're familiar with DOPS. DOPS is the Dialysis Outcomes Practice Pattern Study, and this is data comparing fistulas and grafts on an international basis. This group, there's people participating from all over the world in this data collection, and every year or so they come out with new data. And we do have some facilities in Northwest Renal Network and other areas across the United States that are participating. But if you look at, and they're looking at prevalent patients versus the incident patients. So prevalent are the ones that are currently on dialysis. Incident, remember, are those ones that are new to dialysis in the year that we're looking at it. And you can see this was written in 2008, and you can see that the United States on the far right of each one of these graphs has some of the lowest fistulas. Fistulas are in the blue, and in that magenta color are the grafts. And you can see that we're far heavily outweighed in the graft department than we are in the fistula department when it comes to our prevalent dialysis patients. And when we look at the new patients, we have more patients with fistulas than we do with grafts starting. But more than anything else, we end up with catheters as being the number one place to access for new patients. But this is just looking at the superiority of the functional AV fistula, and there's far less infectious complications. As you can see, they have a 4.4 to 12 times less the infection rate than grafts do. And, in a population that's immunocompromised, it's really important to have the lowest possible infection rates and have the accesses with the lowest infection rates as possible. And there's far less interventional procedures to keep it open and functioning. You can see that, there's a 2.4 to 7.1 times less salvage procedures on fistulas than on grafts. And so that also saves cost to the system. And that's really important. We need to look at overall cost versus, as well as overall impact that we have on the patients as far as lost time, lost treatment, travel time, and having an invasive procedure done all the time. If it were your choice, what choice would you make based on those kinds of things? And also, there's a better one-year primary patency rate in the new patients. So 1 year for fistulas, 68% of those fistulas will still be functional at 1 year versus 49% of the grafts. So that tells me that there's going to be a whole lot more interventions done on the graft side than there will be on the fistula side. And the references for these statistics are listed below. Now, a lot of studies indicate that fistulas have a lower mortality rates compared with grafts and catheters. And also we have to look at the diabetic population. And what we're finding is that even with grafts, it still is tremendously higher, the morbidity and mortality and the cost associated with grafts with diabetic patients, and really, really high for catheters. But in that particular population, and you say, well, of course, we're probably going to see more grafts in the diabetic population because they have bad vessels. Well, we need to verify that. We can't just make the assumption that, oh, you're a diabetic, you have bad vessels. So that's why vessel mapping is really, really important to do, because we have to make sure that they do have bad vessels, because if they can have a fistula based on their vessels, they really need to have a fistula because they're at really, really high risk. And we're going to show you those different risks here. This one is the relative risk of death by access type, and these are the different deaths, the infectious complications and the cardiac complications. And you can see the catheters are in the gold bar there, and the grafts are in the blue bar, and fistulas are in that brick-colored bar. And when we look at relative risk, what you do is you look at the numbers to the right of the decimal. So, for instance, for infectious death rates by access type for the catheters, they have a 70% risk of dying from an infectious complication. And with grafts, they have an 8% risk of death. And from the cardiac side, to die from a cardiac event, it would be a 54% risk versus a 41% risk for catheters and grafts. So you can see it's really high when we're looking at those particular kinds of death events that occur by access type. And now we're looking at the diabetics versus the non-diabetics and their relative risk of dying versus, the catheters, grafts, and fistulas. And when we look at catheters, there's a 91% relative risk of death if you're a diabetic, but 64% risk if you're diabetic. So it's really, really tremendously higher in those two populations. And even when we look at the non-diabetics, there's still a 16% for catheters, 12% relative risk of dying from that access type. But you can see the difference, a 12% versus a 64%. That's a pretty extreme difference between the two types. And then we want to look at the adjusted relative risk of death due to infection by vascular access type. And Dingra and his group has done a lot of the looks at the different types of problems associated with vascular access and the comorbidities. So you can see that it's tremendously higher death due to infection in the diabetic population with a graft, even much higher than with catheters, surprisingly. So, it's really, really important that if our patients do have a graft for an access, that we're doing a really good assessment, that we're paying attention to what the patients complain about with their access. Pain and tenderness are really early clues that we can make sure that we get those patients referred and get them taken care of as soon as possible. And you can see when we talk about adjusted relative risk, you can see at the bottom it says adjusted for age, race, gender, body mass index, history of smoking, peripheral vascular, coronary artery disease, congestive heart failure, neoplasms, and whether you can walk and what your educational level is. And these were prevalent dialysis patients. So now let's take a look at the relative risk of access failure because, the conditions for coverage tell you that you not only need to monitor and to be increasing your number of fistulas while you're decreasing the number of catheters and grafts, but that we also have to make sure that they want us to make sure that they last a long time. And so they give us guidelines on the measures assessment tool of how long that we should expect an access to live longer than. And when we look at the fistulas versus grafts for the risk of thrombectomy, you can see that it's almost fourfold increase of risk of thrombectomy for grafts versus fistulas, and it's a threefold increase for a risk of intervention. So this is a lot of time, and anytime we do an intervention on a patient, of course, they always run the risk of having an infection occur, and perhaps they may not be able to fix that, or they have another event as a result of having some kind of an intervention. So dramatically different in the risk of access failure. Let's look at the cost per patient per year by access type. And this is from the United States Renal Data System, their 2010 information, which is actually 2008 data. So usually everything we get is 2 years behind, and that's why they're collecting all the claims data and information. So this is the annual per patient per year expenditure. And catheters cost $90,110, grafts $79,337, fistula $64,701. So the annual per patient cost savings of a fistula over a graft is $14,636, and the annual per patient cost savings of an AV fistula over a catheter is $25,000, $409. And the individual cost per patient for catheters, it comes out to about $6,400 per patient per year. Grafts is $8,600, and fistulas is $3,400. So you can see it's quite a lot of money for the differences in the access types that patients have. So our fistula first change concept number 6. And if you haven't been to the website, it's www.fistulafirst.org, and then you click on Professional tab at the top, and you'll see ESRD change concepts. And then you can click on number 6. And it says evaluate every AV graft patient for a possible secondary AV fistula. And then the points are that nephrologists should evaluate every AV graft patient for possible placement of a secondary AV fistula, including mapping as indicated, and document the plan in the patient's record. And it goes on to say that AV fistula evaluation of graft patients should include an updated vascular access history, physical examination with tourniquets, and vessel mapping if suitable vessels are not identified on a physical exam. You know, sometimes you put a tourniquet on somebody and those veins pop up everywhere. And, you know, if doctors are really good at doing evaluations, they can almost tell from just looking at their physical assessment whether a patient will have good vessels to support AV fistulas. But in those that you can't tell that, then you need to go beyond that, and you need to do the physical, you need to do the vessel mapping as well as the physical examination. A secondary AV fistula plan should be documented in the chart, discussed with the patient, family, staff, nephrologist, and surgeon in anticipation of AV fistula construction on the earliest evidence of graft failure. This is really, really important. When we've got a nice vessel that's developing as a result of an outflow vein, and we'll show you a couple of those, it's important to make sure that when we're developing this plan that the surgeon knows that, because if the patient presents themselves, say they bypass the nephrologist, they bypass the dialysis unit, and they just call the surgeon's office and say my graft is clotted, well, when the flow from the outflow is not there any longer, that beautiful fistula that we've been watching in the upper arm will disappear because since there's no flow going through there, the vessel goes back to its normal size. So when a surgeon takes a look at it, he doesn't see a beautiful fistula that we've been seeing all along. And so because the patient had a graft in the past, they may automatically assume that they need to have another graft put in the upper arm when there was already a fistula there developed. And so that's why it's really important to make sure that everybody that is going to have contact with that patient knows what's going on and knows what that plan is, in particular the surgeon. So I want to review the protocol for the protocol called Sleeves Up. And it's to identify a suitable outflow vein for conversion from a graft to a fistula. And we don't call it a new fistula, we call it a secondary fistula, and that's because when it's time to do the cannulation, we don't have to start with a 17-gauge needle and work our way up. And as we go through this protocol, I think you'll understand why. So, and there's a checklist that's been created, and it's on the Fistula First website, and I'll show you what it looks like, but I'll talk about all the points that are on the on the worksheet that you can utilize. But once a month in clinic rounds, the reason we call it the Sleeves Up protocol is because a lot of times patients come in with T-shirts or short sleeve shirts. But what we want to look at is the outflow vein of a forearm graft. And that outflow vein is in the upper arm. And so what we want you to do is to slide the sleeve up so we can take a look at that outflow vein on their arm to see if it has, in fact, dilated and developed a nice thick wall. So, for instance, there it is. Isn't that a beautiful looking vessel? And this person has a loop graft in their arm, and so they slid his sleeve up and they saw this beautiful outflow vein. So, once that arm is exposed, then, before you put needles in, you can do a compression there, and you can actually do an assessment of that upper arm piece. And you can press on it, and you can see if there's good rebound in it. And you can feel the margins, because remember, you're supposed to be able to feel the outside edges of a fistula. That's one of the ways that you know that fistula is maturing, is that you can now identify it, and it sticks out from the rest of the tissue in the arm. And then what you need to do is you need to then let the doctor know that you've identified this beautiful outflow vein. And then, so this is how the protocol goes. And you don't do this without having, your medical director needs to sign off that you want to institute a protocol like this when you identify patients. And then you would notify the physician and say, we found this beautiful outflow vein, and we'd like to institute the Sleeves Up protocol. And so the first thing they do in the protocol is to check the fistulogram. And the reason that we want to have a fistulogram is because I want to know why that vessel is so plumped up. Is it plumped up because it got arterialized, because we've got a nice, good, strong heartbeat that sent a good flow of blood through that graft, and then when it hit the wall, it caused it to dilate? Or was it caused because there was an outflow obstruction, or there was a stenosis in the upper arm that narrowed it and forced the blood to go backwards and caused it to plump up that way? Because that's not the way I want that to develop. We need to have it to develop from the heart and go back and go through the access and come back to the heart, rather than having it go from a blockage and go backwards. Because if I fix that blockage, guess what? That vessel's going to deflate, and it's not going to be a fistula for us to be able to utilize. So that's the purpose of having the fistulogram. It tells me whether or not it actually was created by the heart, and we had a good pump that caused that to develop. So when you find out that the fistulogram is normal, that there's no blockages at all, then when the patient comes into dialysis again, the next step would be to, on 2 consecutive days, so 2 treatment days in a row, you put 1 needle in the graft, and you would put 1 needle in the outflow vein. Now, what size needle would you use? Well, you would use whatever needles you were using in the graft. So, for instance, if you were using a 15-gauge needle at a 400 blood flow, you would put a 15-gauge needle in the graft for the arterial, and for the venous needle, you would put in a 15-gauge needle for that, and you would turn the blood pump up to 400 and run them for 2 days in a row. If that vein did not infiltrate with those higher bore, those large gauge needles, and that high blood flow rate, then we already know that that's a mature fistula. So that's the way we test to make sure that that is actually a mature fistula. See, we would never do that with a brand new fistula that we've never cannulated before, but since we know and we've been running this patient for a long time at that rate with those needles, then we're assuming that that vessel can withstand that pressure and that high flow, and then we test it by actually putting just 1 needle in there. So if they're both successful then, those 2 treatments, then the next step is, when do we convert that graft to that upper arm fistula? And so what you need to do is, we have to have the surgeon, we have to have the patient, we need the staff, we need the nephrologist. We need to talk about when it is we're going to just take the artery and attach it right to that upper arm vein and let that graft go. And some people go, well, if that graft still works, why would I let that go? Well, and that's valid. And you may not want to let that go. And so what you want to do is that's where everybody gets together and has a plan for when is it the right time then to do that conversion. And then we make sure that we follow that until we get that conversion to occur. So here we go. You can see the loop right here. You can see the needles are side by side. There's this beautiful outflow vein. So, and what we would do is see the artery is over here and the vein is over here. For that surgery, we want them to take this artery and take it and connect it right over here to this vein. And that's why we would lose the graft piece, because we would take the blood supply and just connect it right here. So here is the checklist, and so we're down to this part. If cannulation successful, discuss the plan with the multidisciplinary team and patient. Plan A, immediate conversion. You may want to do that. You may immediately want to schedule surgery and convert that. But Plan B says wait until access dysfunction is evident. Well, what does that mean? Well, how many times do you let the patient go back to get their access cleaned out after it clots? Because once you start doing that, that's considered the access is starting to fail. It is an access dysfunction event that's going on. And so you might want to take a look at that. It could be that you're seeing a pseudoaneurysm form on that access, which means that it's been punctured too many times in the same small area, and you're starting to get now those bumps on the access. Or when you palpate your graft, it's starting to get mushy in parts. That is a dysfunctional access that's occurring. So you can, what happens if you start to have decreased blood flow rate? So if you decrease by 25% your flow, that sort of thing. So the doctor can choose whatever he wants to describe when it's time to get him scheduled for surgery. So the criteria conversion could be impending graft thrombosis. You can wait till it completely clots, although remember what I said, that beautiful outflow vein will not look like that when there's no flow coming out of the graft. So when it clots, it will go back down to its normal size, or other. So you can put, well, if it drops or if they've had 3 interventions on the access, we're going to consider that. Now it's time to schedule the surgery. So it might take a month or so to get that surgery scheduled. Then the next step, number 5, surgery for secondary AVF, access has been scheduled. So you want to put down where they're going to go for their surgery and who's going to be performing it. And then there's a place to put the date in. One of the things that you want to do always when patients are scheduled for interventions is somebody should really kind of make a follow-up call, like the day before their procedure, to say, remember, you've got your surgical appointment tomorrow, and have you got your transportation all in place? And do you know what your instructions are before you go to bed, whether or not they want you to not eat anything, whether you're allowed to have some clear liquids, when to take or what medications to take before your access procedure. So it wouldn't hurt to remind them just to make sure, because a lot of times a patient shows up to dialysis, you go, well, you had your surgery? Well, no, I didn't have any transportation, so I had to cancel. We can avoid those things by just a little, it takes me probably 10 or 15 minutes out of my work day to follow up with that, but you know what? That may be the difference between the patient actually getting their surgical procedure and not getting their surgical procedure. And then you have to reschedule it all over again, And so here's a nice checklist, and if you look at this, there's the patient's name, who's going to be in charge, who's assigned to monitor this patient, and then what date was their graft originally put in, because that's kind of important to know. And then if you do the sleeves up and they don't have one of those good outflow veins, you put the date and you check no. And that's all you do for that month. But you keep checking every month And then if and when you do see that beautiful outflow vein, then you'll have the date, you'll have the yes check, and then you'll notify the doctor to get some other orders. And you just put the dates in there. And then everywhere there's a place for dates and for information. And then that goes in the patient's chart or the vascular access manager if you have one. They keep that, and this keeps our patients from falling through the cracks, from losing their grafts, and ending up with new grafts and things like that. Because if we can get a graft that can turn a patient's vessels into a fistula, that's a really good thing. And that may be one of the ways, that may be an alternative to placing a catheter in a patient, is to have them have a graft placed and then have it mature into a fistula. Now, they may have to have a fistula for about a week because we really need that anastomosis to heal well. And then when we start to use that fistula, again, we're not going to start with 17-gauge needles because it's already a thick-walled, mature fistula that we've tested at a higher pump speed with higher gauge needles. So then we would start with those higher gauge needles at that regular blood flow rate so that they don't start on adequacy by starting up using this access. So that's the difference between a secondary fistula and a brand new fistula, is that we don't have to go through that startup process. We just go bang right from there. And so that works very, very well for patients. And, having a catheter for 1 week is a whole lot better than having it for a month or more. But here's the question. Can converting grafts to fistulas really have an impact on your AV fistula rate? Well, yes, and we'll show you one particular incident. Our champion nephrologist in our network is Dr. Von Wynn from Olympia, Washington. And this is showing when he learned about converting grafts to fistulas, it's exactly what he did. And his fistula prevalence, and the fistula prevalence was 41% here. He actually was able to increase it to 71%, look at this, by reducing grafts and converting those grafts into fistulas. And so, and he has been able to sustain very high rates for the entire 8 years or so that we've been doing this Fistula First project. And you can see he's got nice low catheter rates as well. So, what was his secret? Well, his secret is that he tells his surgeons, no grafts. He wants AV fistulas only. And when a graft comes into his clinic, his plan is to get him to the surgeon and to get him vessel mapped and find good veins so that they can get fistulas placed. So his belief, which we believe, and if you hear talks nationally, they say the nephrologist needs to be in charge of the patient. They need to be telling the surgeon what type of access we need for that person. And they need to be familiar. Now, he actually went and learned how to do vessel mapping because he didn't understand any of that. But he went to the surgeon and had the surgeon teach him. So now he can do his physical assessments on his patients with a tourniquet. And he can look and he can read what those vessel mappings are. And then he can pick out the vessels. And he can talk and have conversation, intelligent conversation with his surgeon. So his piece to success, vascular access is a team effort. Everybody's involved. He's got technicians and nurses and interventionists and the surgeon and himself, and they're all very active and they meet together. But he's in charge of his patients. He's the nephrologist, and he thinks that it's important, and his success he's found is from him being in charge of that patient and that patient's access plan. Of course, in conference and in having conversation with his patients. He doesn't make the sole thing, but he's got a patient there that he has conversation with. And you plan before a fistula long before it's needed. That's very, very important. And then educate patients and their families. I'll share a story with you. He had a patient that he had placed a fistula in many, many, many years ago. And told that patient, you need an AV fistula. Grafts and catheters aren't good. You need to have an AV fistula. So they had an AV fistula placed. Well, they moved around from clinic and state to state, and she ended up in one state, and she was having problems with her fistula, and she went to a surgeon, and the surgeon said, you need to have a graft. She goes, oh, no. No, Bo said no. And the surgeon goes, yes, you need to have a graft. She actually moved back to Washington and went to Bo and said, Bo, my access isn't working right, and the surgeon told me I needed to have a graft. And so he sent her back to the surgeon. They revised it, and she is still using that same fistula. So he educated her very well, and she said, no, no, no. You know, my doctor said that, no, I don't need a graft, that my vessels are okay and they're suitable for fistulas, and I still want my fistula. And so that's really important that patients get the message and they understand. Otherwise, she wouldn't have had the best access. And she's had that access for well over a decade. She's probably on closer to 2 decades now. And then we need to use new surgical approaches. The surgeons are always trying to find a better way, a better way of teaching, incorporating teaching with new residents. And so we've got new doctors, new surgeons coming out that have been actually have some training on some new of the surgical approaches. But, you know, one of those keys is that you convert all grafts, that you stop revising them, but you look ways to convert them into AV fistulas. And you've got to ask the question, why did that patient get a graft to begin with if they were able to create a fistula in their upper arm? And probably the answer is that they probably were not vessel mapped. And so there was an assumption made based on some comorbid conditions that that patient probably required a graft. So now we have to stop making assumptions, and we have to use the tools that we have access to, which is vessel mapping. And then for late referral, he actually considers peritoneal dialysis and having the patient have a fistula placed at the time they have their PD catheter placed. And that way, that in the event they find out that PD doesn't work really well for that patient and they're not getting good clearances, that they already have the fistula and it's already matured. So if they have to go back to hemodialysis, they already have an access that's ready to use. And then to maintain a checklist for each patient. We need to keep track of them. We don't want them to fall through the cracks. And he's a big advocate of training staff. He goes into his dialysis unit and he trains the staff, and the staff train him. So education moves both ways in his unit. And then you need to monitor the results of your CQI program. You are, through the conditions of coverage, required to continuously monitor your vascular access. And so it's really, really important. And, of course, he was one of the leaders that kind of helped shape what Fistula First was all about and our change concept, because this article, His Keys to Success, was published in 2003. So we started the Fistula First Breakthrough Initiative in 2003. So, has it contributed to our success? Well, if we look at 2003 to 2007, so this was the first 4 years, if you look at the green line where the red arrow is, look at our graft rate. It was about 25%, and it went down to about 15% over that 4-year period. As our in-place, our in-use, our maturing is the top solid one in the AV fistulas in use. We went from about, it looks about like 52% to just a little over 60%, 61% or so. So it did have an impact on that. So as we saw our fistula rates climb, we saw our graft rates decline. And this is, when we look at this, our statistician said we have a 99% confidence that it was because of our decline in AV graft use. And instead, that's what caused our AV fistula rates to go higher. And so now let's look at the distribution over 8 years, and the graphs are the bright green on the top. And you can see back in December 03, we had 24.3% of our population in our 5-state network region had grafts. And you can see that we're down to about 13% now. So you can see that as our fistula rates grew over time, our graft rates declined. because you can see that in the middle there, the burgundy color here is the catheters greater than 90 days. Here's the catheters less than 90 days. And these are the ones that have catheters with fistulas maturing. And then these are the ones that we're actually using in the dark here. And initially when we started out, we had some missing access types. We're now down to missing access types. So we know all of the accesses now that we're using. So at the end of in December 2010, you can see we had reached the national CMS fistula first goal of greater than 66%. We were at 66.4%. We reached that goal in November of 2010, and we're currently, yesterday's dashboard came out, and we are at 67.7% AV fistula rates. So hopefully when we see December 2011, it's going to be a lot less grafts. So we want you to be a Network 16 champion. And these are the people that were initially involved, been driving the process over the last 7 years or so. And, we want to see your picture up here, too. We want to see your nephrologist here. We want to see your surgeons up here. We want to see your nurses. We want to see your technicians up here. We want to see your patients. Because you have to be the change that you want to see in the world. We can't rely on outside forces to say change, change, change. You have to go, wow, we can do this and we can make these changes. And I think that's really, really important that you know that you can do it. And we have been very successful in this network to be able to drive change. So if you need more information, you can always send me an email or give me a call. Our network website has resources for you there. The fistulafirst.org website has the protocol on there for you to look at and for you to utilize and institute. So, you would have to go to your medical director, have conversation with the medical director, and then the medical director is in charge of overseeing the quality of care in your dialysis unit. So he can get the nephrologist together and say that, this protocol is available, and that's one way to drive your rates up, your AV fistula rates up. And so that's this is one way that you can do that when you have a lot of grafts in your facility. In 2014, the Quality Incentives Program, which is going to either give you full reimbursement for the work that you do, or they're to deduct monies from your dialysis treatment that you're providing. The proposed rule is that they're going to look at your number of catheters versus your number of fistulas, and you'll get points taken away for your catheters, and you'll get points given to you for having fistulas. And it doesn't say anything right now. They haven't described what's going to happen if you've got lots of grafts. Are you going to lose revenue because you've got a lot of grafts but not so many catheters? So that's something we want to be on the lookout for in November. They're supposed to come up with what the proposed rules will be final rules to see about how they're going to do that measurement and whether or not they're going to give you some kind of points for having grafts, which is better than having catheters, or if they're not going to include those at all and just look at the two ends. And the payment year 2014 is actually for the data they collect in 2012. And 2012 is right around the corner. So it's a good idea to start looking to see if perhaps you can convert some of those grafts that are convertible into AV fistulas so that at least in that particular category you'll get as many points as you possibly can for the reimbursements for the Quality Incentive Program. I know that's probably making everybody crazy, but it's something that we have to look at, look far in advance for what they're going to measure us on, because remember, they collect the information 2 years, like currently they collect it for payment down the road. So that's really important for you to pay attention to. So we've got some time now, and if you want to ask a question, again, please don't identify yourself or your facility. Just ask a question, and there'll be a poll that will be popping up on the screen. So before you hang up, even if you don't have questions, please take a minute to answer the poll. And again, press *6 to unmute your phone and ask away.
Linda?
Yes.
We have a lot of leg grafts because they've already failed at fistulas and even arm grafts, so you're not going to have an outflow vein to do anything with. Do you have any suggestions?
Well, by the time they get down to the legs, that probably is an indication that they've been on dialysis for a while and they've lost most of their accesses. What you do want to do is make sure that you take really good care of that access, and do your cannulations appropriately so that you don't wear it out. And you're right, there's not a whole lot you can do with leg accesses, but that tells me that that patient has pretty much gone through most of the vasculature in their upper extremities.
Correct, yeah.
Another alternative if the leg grafts fail, another alternative might be to consider to put in the hero graft back in one of the upper extremities, because it doesn't involve the venous system at all. It attaches to an artery, and then it does not attach to a vein at all. It attaches to an outflow device that goes right into the right atrium of the heart. So you don't need the venous system for a hero graft. So if and when the leg grafts fail and you're going, okay, they're catheter dependent now, stop and think about the hero graft before you go back to catheter only, because I think that's going to be important when we've exhausted absolutely everything.
Okay, all right, thank you.
You're welcome. More questions? All right, well, as soon as you complete the poll then, you can hang up, and I want to thank you for joining me today. Goodbye.